Another challenge in our glaucoma practice is when we see OCT image, so many reds and so many greens in there. So always we are confused. So I invite Dr. Smita, who is my own teacher, and she's working as a professor in the Government Medical College, Thrissur, and she'll be clearing all our doubts about this red and greens in OCT. Over to you.
Good morning, ladies and gentlemen. Thank you, Dr. Jaini, for this wonderful opportunity. The OCT machine is very easily available in most of the eye hospitals. There is a thrill in using this sophisticated and very rapidly advancing technology, both for the patient and for the ophthalmologist. And most importantly, it is very easy to use. So, with all these advantages, there is a real temptation for the doctor to use that color-coded printout to make a diagnosis of glaucoma. And it is here that we should be aware of its limitations. So this was a study done by Stagg and Medeiros, and it was for glaucoma suspects. They found that in a spectral domain OCT of the RNFL, at a sensitivity of 95%, specificity is only 60%. This means that if you want to detect 95% of glaucoma in glaucoma suspects, you end up calling 40% of the normals as glaucomatous. So since we basically use the OCT to find out whether the glaucoma suspect is having glaucoma, that is to make a decision whether the glaucoma suspect is having glaucoma or not. Because this specificity rises very much, it becomes something around 95% if the person actually has glaucoma, mild, moderate or severe. So that is why we should say no to the screening and random diagnosis of glaucoma using the imaging techniques. Now I'm going to speak about the red disease and the green disease. So if you look at this picture, in this thickness, in this RNFL thickness differentiation map, you can see that there is this red area which is large. You can see it on the red-free fundus, red-free and also in the fundus picture. But when you look at the fields, there is a superior field effect. So basically there is no correlation, and this red color is not probably glaucomatous. So the red disease is actually a false positive diagnosis for glaucoma, as the device incorrectly indicates an abnormality in red corresponding to the image when there is no damage. So this incorrect damage, like it is like a terrified patient coming with an OCT created damage, which is the red disease. It has greater patient anxiety and cost, unnecessary treatment with its adverse effects, and sometimes may lead to medico-legal issues. So let us look at some of the causes. Most of the OCTs need to function with at least a minimum signal strength. For the spectralis, it is more than 15, and for the cirrus, it is more than 6. I've given the value for others also. So for each unit decrease of signal strength, from the baseline, the average RNFL thickness decreases by 2 microns. So you can see the poor signal strength in this red-free image, where you can see that the branches are not visible in certain areas. You can see the highly granular appearance in the B scan. And so this usually happens when the lens of the OCT machine is not clear, or there is a dry eye on a cortical cataract, and very paradoxically also in pseudophakics. So signal strength has to be established, and it is always written down in the printout. The second important cause is decentration of the measuring ring. You can see that this measuring ring, which should have been centered on the optic disc center, is now decentered superiorly, and therefore the superior part appears thinner as compared to the inferior part, though not in this sectoral map. You have to discard the scan and take another one in which the ring is properly centered. There could be an anterior misidentification of the RNFL. You can see in this area so it is important that we look at the screen, and we should be there in the same room as the OCT is performed, so that we can correct the position manually and then measure the RNFL thickness, because otherwise this position, if we take it in this position, it is likely to appear in red. There could be also posterior misidentification of RNFL. You can see these green lines which show the posterior border of RNFL touching the red line at many areas, and that is basically a segmentation failure of the machine. You know that even if there is a long-standing optic neuropathy with, say, no perception of light, there would be some residual glial cells or retinal blood vessels which would give a base thickness of, say, 30 to 40 microns. That would be always measured. There would be nothing which touches the floor, like in this picture. You can see that the patient's OCT is touching the x-axis, and therefore it is giving something in the red here in the sectoral and the clock-R maps. So when this was corrected, this gives rise to a normal OCT, normal pattern as is shown in this printout. Another very common, very important thing that can happen is to have a floater on the measuring ring. Now this floater can be patient's own hair or the patient's clothes interfering in between, or it could be a vitreous floater, or it could be the measuring ring straddling across the peripapillary atrophy, or though the myelinated nerve fibers would give rise to a thicker picture, or a PVD. So in the thickness map, you can see the presence of any of these in the form of a non-acquisition of signal in black color. On the other hand, in the deviation map, this comes as a red color straddling the disc, and therefore, since the signal is not acquired, it will lead to a yellow or red disease in your clock-R maps, and falsely you can think that the patient is glaucomatous. Most of the times, the hospital where you work won't have the latest OCT machine, or the technician would be new and inexperienced. So the patient may be moving, sometimes the patient may have poor vision and may not see the crosshair of your OCT machine, and therefore the patient would be moving, and then there would be motion artifacts, and such OCTs should not be used. You have to discard them and use and do another OCT. They are best seen by these horizontal lines where the blood vessels, you can see that the continuity of the blood vessels is lost. This horizontal line is more clearly seen. The database with which we compare our patients is usually Caucasian in case of the spectralis, or in the case of cirrus OCTs, there is only about 1% of patients who are Indian. So basically we are comparing our patients with a very, very small database, and therefore the chances of having red disease because of this racial difference is always there. Indian database, I do not know if it is available now, but we must have an Indian database, and many studies, because India is so diverse, many studies show many different kinds of databases. There is no normative database for people less than 18 years of age, or congenital disc abnormalities of very small or large disc, and most importantly, in pathological myopia, you will have a patient who is unable to fix the central crosshair. You will have a patient who has motion artifact because he or she is uncomfortable looking into the machine, or there may be peripapillary atrophy or the floater straddling on the measuring ring, or there may be a normative database absence because the patient has more than -12 diopters of myopia, or there can be a lateral displacement of the RNFL bundle or an anatomical split of the RNFL bundle. So there are so many things which make the diagnosis of glaucoma by the OCT machine very difficult. This was actually a poster by one of my PGs who again reiterated the same factors. Let us now come to the green disease. The green disease is when there is a false negative diagnosis, meaning that the software interprets that there is actually glaucomatous damage when there is no glaucomatous damage. So we feel complacent, we feel that the patient has no glaucomatous damage, that is a false sense of security. This is from a paper by Sunny et al., where in this RNFL, in this red-free map, you can see this RNFL defect, which is seen in the thickness map, which is seen in the deviation map also, but is not seen in the clock-R map. In the similar way, there is in another case, there is this RNFL defect. In here, you can see this RNFL defect, which is present in the thickness map, but which is not acquired in the deviation map, and neither in the clock-R map. So there are chances that the deviation map and the Clocker map may not show the defect which you are actually seeing in the patient's eye, and therefore show a green disease. This is a segmentation failure. This is another patient who had a cup with an inferior Drans hemorrhage, and this Drans hemorrhage showed in the deviation map also, besides in the thickness map, but was not seen in the sectoral and the Clocker maps. So this is actually a averaging algorithm which doesn't work, and there is this averaging is not a simple averaging algorithm. It's a interpolation of data from the neighboring areas which gives rise falsely to a green color. PVDs can cause traction on the optic disc and pull the disc up, leading to a false security that there is glaucoma, when in fact there is no glaucoma. When the PVD collapses, this thing will disappear. And finally, again, I want to reiterate that the OCT is only helpful to make a diagnosis. You should have a complete workup of the OCT, just as you do for the visual field, and then you make a diagnosis of glaucoma only by basing on the history, on the optic disc, and the visual field changes. OCT is only a helpful tool. Thank you very much for your kind attention.